Polycythemia vera has really gotten interesting. For the longest time, we were limited to hydroxyurea, and then since 2014, ruxolitinib for the treatment of polycythemia vera, with some use of interferon, which was never formally approved for this disease. So in recent times, there's been a couple of very interesting developments. One is the drug Ropeginterferon alpha 2B, which is already approved in Europe. I want to say the approval came in early 2019. I could be a year off there because the pandemic makes things blurry, you know. This drug is approved in Europe, in the European Union, for patients with polycythemia vera without symptomatic splenomegaly. So this is a very interesting frontline choice that is available today in the EU and hopefully will be available in the US. This was based on the PROUD and continuation PV phase 3 studies. And Ropeginterferon alpha 2B is an interferon, as you can tell. And its uniqueness lies in the fact that it is particularly long-acting. You can give it every 2 weeks instead of every week, like regular pegylated interferon. And the results were very impressive from these trials in terms of complete hematologic response rates, disease burden reduction rates, and of course, molecular remission rates. Tolerability was also very good. So really excited about this. And also, it's important to note that this drug was also studied in low-risk PV. Now, that's not necessarily what the approval is for, but it has been studied in low-risk PV. And remember that low-risk PV is managed with phlebotomy and aspirin, pretty much. So this could be a paradigm shift. It could be really practice changing if it begins to be used in low-risk PV. There was a study called the low PV study that Dr. Barbui and colleagues led, and it was overwhelmingly positive. The other drug that is of interest in the field of PV is Rusfertide. Rusfertide is a hepcidin mimetic. So it's a really clever mechanism of action where what you're trying to do is mimic the action of hepcidin so that iron is not available for erythropoiesis, so that iron is sort of sequestered in the reticuloendothelial system and not available for the bone marrow to use to make red blood cells. So this is a drug that's given subcutaneously once a week. It is not approved anywhere yet. This drug is really good at controlling the hematocrit and eliminating the need for phlebotomy. The results were most recently disclosed at EHA in an oral session, EHA 21, and prior to that at ASH 20. This drug seems really good at preventing the need for phlebotomy by controlling the hematocrit in a sustained way, which is important. And by doing so, also improving iron deficiency. So improving all the iron markers and also controlling the symptoms of iron deficiency. So as I see it, the drug has the potential to provide a sustained hematocrit control, which to me could be attractive because it might obviate the need for repeatedly checking the hematocrit and doing phlebotomies as needed.